One. A
Thank you.
hearty good afternoon to everyone, and welcome to a session on previous pregnancy loss and subsequent pregnancies. We are glad to have Dr. Nuzhat Aziz among us today to help us understand the topic. The doctor will help us understand a little bit better of how to cope with previous loss of pregnancies and how to deal with handling successful subsequent pregnancies. So, doctor, you have the stage.
Thank you, Sean. Thank you so much, and a good afternoon to each one of you. And thank you for the entire Apollo Cradle team for this opportunity to be on your platform. And this is my first session, and the topic that we will talk about or go in detail would be planning a pregnancy after a pregnancy loss. Why did we choose this topic, or why is it that we need to focus on it differently? Is women who have had a previous pregnancy loss find it extremely difficult to gather hope and plan a pregnancy again. They find it very difficult to deal with that state of their life wherein it ended into an uncertain outcome. And we also wish to talk about this topic because it's a kind of a social taboo. People don't talk about it. We are not, as a society, geared up to talk about stillbirths or a pregnancy loss, and that results in this woman being isolated and not actually having the support that she requires and needs. Is it an uncommon thing to find pregnancy loss? So, if we have 100 women who have all attempted pregnancy, we will find that 15 to 20% of them have had a pregnancy loss. So it's not uncommon. It is pretty common among us. We only don't talk about it because we find it very uncomfortable to talk saying I've had a miscarriage in the past or I have had a stillbirth. What do we doctors mean by a pregnancy loss? When it occurs in the first 20 weeks of pregnancy, we call it a miscarriage. From 20 weeks onwards to term or to the birth, then we call it an antenatal stillbirth. A special term that when the baby's heartbeat stops during the process of birth, we call it an intrapartum stillbirth. And if it occurs immediately after birth, we call it a neonatal period. Why is it that we need to talk about and care for these women in a different way? If we take a look at a couple who walks in for the first time with a pregnancy, you will find them that they are such happy couples. And with a lot of optimism, hope, they look forward to every investigation, every interaction with the doctor. They look forward to the birth of their baby. But on the other hand, if you find a group of women who have had a previous pregnancy loss, you will find them very anxious, very fearful, very worried, even to visit the hospital, to undergo an ultrasound, to meet the doctor, because they feel that you don't know what's going to come next. So it is a very different group of women that we will be dealing with. Why do pregnancy loss occurs? And this is the most common question that everyone asks. Every woman, when it comes to a miscarriage, asks you. The causes for pregnancy loss in early part of pregnancy are very different. It can be genetic, it can be infection. Whereas in the later part of the pregnancy, they are usually placental causes or any growth problems that have occurred, or it can be diabetes, hypertension, antibodies directed against the placenta. But important for all of us to remember is that your doctor is going to look out for these 9 basic factors that we intend to control or be able to target them in the next pregnancy. But many women find it very difficult to go back to their previous pregnancy and talk about it. I have come across many couples who have actually thrown their file off, and they kept on opening and looking at the ultrasound images. They did not want to do that. So what they did was just throw it off. We don't want to revisit them. From our perspective, we need to know the cause because some of the conditions can still persist. Like, for example, if a woman has chronic hypertension, then we need to control it and then plan a pregnancy. Some conditions occur again in pregnancy. Like, for example, if a woman develops diabetes in pregnancy, then her chances of having that disease again is very high. Sometimes some diseases may be genetic. The reason can be. We need to find out what was the abnormal gene. We need to find out whether this is a recurrent problem which has come, as an inheritance, or it is something that occurred de novo and may not occur again. So basically, the healthcare provider, tries to identify preventable or treatable conditions. So we look at all the reports possible. No paper is not an important paper in evaluation of a pregnancy loss or stillbirth. We try to look at all investigations done, the gestational age or the period of pregnancy at which the loss occurred. It is very important to calculate it, sit on a chart, and say, well, what was your expected date of delivery and when did the event occur. The birth of the baby, the gender of the baby, any test that were done on the placenta, especially autopsy or on the baby, and whether the results are available. So I am going to talk about a few of them which are preventable causes, and the knowledge of these conditions are going to be helpful to us as we plan or move forward to support a woman who has had a previous pregnancy loss. The first and the most important condition would be a fetal growth restriction. It is an important preventable factor. What is very important is how do we estimate or say that this is the optimal weight and this was normal. So, a woman who comes to us and says that she had a baby boy born at 40 weeks, 2.5 kg, 2.5 kg looks pretty okay and normal for any term pregnancy or a birth. But if we were to plot her chart onto an Indian chart on ethnicity based, or more accurate to be based on her height and weight, then you will find that the 2.5 is coming way below her optimal or expected weight that is expected for that baby at this point of time. And this is very interesting because this suddenly after birth we realize that it is lesser than what it should have been. Could we have identified this before? Could we have predicted this? If we were doing serial growths for this baby, and if we were to plot them onto a chart, on the similar chart, and then we would have realized that the baby is not going in the manner that it is expected to be, but it is slowly having a decrease in velocity of growth that is occurring over here. And maybe an appropriate time delivery at a point where it is becoming abnormal could have prevented. These kind of charts are also very helpful to identify where an intervention is needed and not needed. Like, for example, this baby is on the smaller side, but growing very comfortably from one point to another point. The second most important factor, especially in India, 40% of the stillbirths are believed to be birth related, is birth related or intrapartum stillbirths. At the beginning, I would like to say that the natural way of childbirth is a vaginal birth, and vaginal birth is much safer than a cesarean section. It is designed by nature, and nature can never be wrong. What is appropriate for us, or our responsibility, is to put up an adequate monitoring facility for low risk mothers and high risk mothers as to how we are going to monitor this baby. If this baby is taking the stress of contractions very nicely, or the process of birth is moving on smoothly as it should be. So, this is our responsibility towards every birth that we have. The next important cause of stillbirth in India is diabetes. India is believed to be the diabetic capital of the world, and diabetes can result in miscarriages, in cardiac abnormalities, in any abnormalities, brain abnormalities, multiple abnormalities, stillbirths, or a neonatal death. We can do a fasting blood sugar to identify it. The next important cause would be the antiphospholipid antibodies. This is the most common treatable cause of recurrent pregnancy losses. Sometimes you will find a woman who's come with three miscarriages, one stillbirth, and having no life issue. And the first thing that we, as care providers, go back is basically to look at does she have antiphospholipid antibody syndrome. It is antibodies directed against the placenta that does not allow it to grow and does not allow the pregnancy to grow. The next two causes that I'm going to talk about is smoking and alcohol. These are avoidable, preventable causes of fetal death. Yes, it is very difficult to make a woman refrain from taking alcohol and smoking. But then, with support, pregnancy is a time where mothers have the best possible compliance that can ever be designed for any condition or medical condition. So, alcohol and smoking should be looked out for, and in case if we don't ask, then we miss this out. Now, once we look at the possible causes or preventable causes of miscarriage, the next question comes is when can we plan the next pregnancy? We used to be traditionally told that a 1 year is good, or sometimes 3 months is good. But then the right time is when the woman feels that she is physically and mentally fit to have a pregnancy. For cesarean section, we continue to maintain that 1 year is an ideal time because the wound on the uterus that was taken to deliver the baby takes a little time to control. Once a couple is ready, okay, have a pre pregnancy plan. Start taking folic acid, which is a vitamin known to prevent the most common birth defects in India, that is the neural tube defects. So quit smoking, have a healthy lifestyle, and then, okay, move forward. It's also very important for all of us to remember, whether it's the society or the healthcare team, that when they plan a pregnancy, the amount of pressure that comes from the family as well as the society is very intense. I still continue to say that try for a 1 year period and we will give you medications. Only if you don't. Most of the women would have conceived by that time of waiting, of trying to have a pregnancy for 1 year. I also tell couples not to announce their pregnancy when it occurs till about the third month. Ultrasound is over. Once the 12 to 14 weeks goes by, the risk of miscarriage or pregnancy loss drops down drastically to maybe 1% or 2% or not more than that. So wait for the third month just to protect yourself emotionally from the society pressure or the family pressure. The pregnancy was tough, but outside life of my pregnancy was even tougher. This is what many couples have told me. One of my couple who was with me throughout her pregnancy after having a stillbirth told me she actually left India, went to Dubai for asking for a transfer because she could not manage to withstand the questions that were coming on to her. Now, doing this kind of a care in a specialized clinic with a team that understands that these women have a different need or an emotional need, that they require privacy, that they require a specific time, a longer time when compared to other people, an environment that is conducive to their needs is very important. And many of these specialized teams have been found to be very helpful around the world. It is also very important for us healthcare providers to ask for permission whether they are open to sharing the knowledge, to discussing their past events. Some of the women would tell you, I don't want to talk about it. It's always better to talk about the current state and then say that, okay, we will revisit this episode maybe when you come back later, when you are, in a much better frame of mind to discuss diagnosis, to plan investigations, to plan for the next pregnancy. We have to review all the medications. The first response from a woman who has had a previous pregnancy loss and who's on a chronic medication is to stop that medication because in somewhere in our head it will come that maybe this drug caused my pregnancy loss. And what they do is they just stop it off, even if it's very important for their medical condition. So it's very important to review all their medications, discuss them, and reassure them that these medications in this dosage is not going to harm your baby or needs to be continued. The information that needs to be given to these women has to be with empathy, with lots and lots of hope, and without any medical jargon. That is common, easily understandable language, revisiting them and asking, do you want me to repeat what I have said? Also remembering that as you do the investigations, as you plan the pregnancy care, even small deviations like hemoglobin up and down, which may not really damage the baby in any way, might trigger an alarm. So any deviation from normal causes a kind of intervention. Moving across to the next aspect of care, that is interventions in next pregnancy. It is important to remember that all the interventions that we talk about have to be evidence based. Only those that have a positive effect or that are capable of bringing about an effect has to be explained, because these women will listen to you no matter what. Okay, if you tell them complete bed rest, I've seen women who have not got off the bed for 3 months, did not have a bath because they were told that your chance of a baby, healthy baby would be much better. So they are willing to do anything that we say. So it's very important that we remember that we talk about interventions that are known to be better, that are known to promote well-being of the fetus. Ultrasound for fetal well-being will be done in a huge number when people come with history of previous pregnancy loss. But every time we send them for an ultrasound, we have to remember that it's a trigger for previous pregnancy memories. Most of these women would have had an ultrasound to diagnose that the baby's heartbeat is not there. We have to educate them about the fetal moments, what is normal, what is abnormal, what should be done, and what is the ideal way of managing decreased fetal moments. Some of the times I've admitted them. Because anytime you talk about any intervention, and if they were not able to do it, they go on a trip of self blame and self guilt. And it is our responsibility to ensure that we don't take them in a path where they start blaming. You asked me to do this and I haven't done. You asked me to take bed rest and I did not do it. I could not do it. And that's something that we have to make a conscious effort to avoid. Many times, when we meet these couples, you will find them that they are in the stages of grief. If you meet them very early, it might be anger, it might be frustration against the other doctor or yourself. Many times they come back to you, and ask you. So you never know when you will meet them. It might be depression, it might be extreme sadness that you come across, or we need to allow women to express themselves, address their fears, and always acknowledge the loss of life. What they are going through is something that you and I cannot imagine, cannot ever step into their feet. It sometimes can be very overwhelming. So it is always okay to seek support. I sometimes find it difficult to help out a woman who requires a professional or a trained counselor or a psychologist. So always asking for help. Having your team with a counselor is always very helpful, and the way they talk is so much better than the way that we are taught. This emotional liability becomes very difficult, or it comes to an extreme degree when they cross that period where they had the pregnancy loss. If it occurred as a miscarriage in the early part, once they cross that period, they are pretty comfortable, and they've crossed the time period. But if it occurred at 36 weeks or 35 weeks, they find it very difficult to reach that gestational age. I've had many mothers insisting that, I lost the baby at 32 weeks. Why can't you take it out at 31 weeks? And we continue to tell them that this is premature time and it's not the ideal time. So talking about the timing of birth is also very important. Looking at their fears. Maybe sometimes we have admitted women and allowed them to birth in our institute, being in the hospital and having a proper neonatal care. We have to inform the neonatal team that she had suffered a previous pregnancy loss and they need to look at the baby in a different way. So what I would like to end is by saying that stillbirth is an enormous a tragedy that falls on a woman as they plan with lots and lots of hope to have a healthy baby at the time. And we overlook it in so many ways, not only as a person in the society, but also by the policy makers, by each aspect of the society. India has a stillbirth rate of 13 per thousand. UK has a stillbirth rate of developed countries have maybe 3, 4. So it just gives you an idea that there is a scope for preventing so many of these stillbirths that happen. We need to support these couples and families to plan a pregnancy again. And I would like to end by saying that, no matter what the chances of recurrence are, let's say they call it 10%, your chances of having a healthy baby are still very high, to the extent of 90%. So with that hope, faith, and lots of love, we plan the pregnancy. And in majority of them, we succeed in having a healthy baby. So with this, I would like to end and look forward to any kind of questions that you are having. Thank you so much. Thank you, Sean. If there are no questions, then a dedicated clinic is something that these women require, and I would uh, love to be a part of the team that's providing uh, any kind of a clinic or an effort to reduce stillbirths, as well as provide care for women who have had suffered a pregnancy loss. Thank you so much.